All right, I'm going to go ahead and get us started because we have a very, very robust agenda for today. This is the second in what we know will be a series of meetings. We'll hold them every month. Hey, Marcus, could you go to the next slide for me? I just want to walk through the agenda real quick. And, you know, so one of the things that a couple of people asked after the last call, what is this whole thing about? And what I really wanted to do is to start to try and provide an opportunity for us to all share with each other, to learn from each other, to, you know, if somebody had some project that they needed help with. But one of the things that certainly came out of our last call was the
Tanya joined the meeting.
Put together some sort of training calendar, which we've also done, and to work on advocacy issues, everything from, you know, I think we've gotten a few updates now on the HIV committee, as well as the viral hepatitis elimination plan. I know Rachel's going to talk to us today about where we are with viral hepatitis. And to, again, like I said before, to do some advocacy training. Somebody just sent a note and I don't have my reading glasses on. I'm not able to join with video as I just learned to me. Okay. Sorry, somebody's not able to join with video. But this is all about developing partnerships, collaborations, and that we're gonna kind of do this together. I want to go back a minute and say, with CEG, our goal is to deconstruct the silos which exist between viral hepatitis, substance use disorder, and HIV. And what I really believe is that it's going to take all sorts of partners, MAT providers, local health departments, food and nutrition programs, family planning programs, you name it, because everybody's involved in one way or another in this piece. And one of the things we felt like we could do is really to help with the training and advocacy pieces of this. So we're putting together a training calendar with some of our partners like Gilead Sciences. We've reached out to Merck, we've reached out to ViiV, we're contacting the AIDS Educational Training Center, and others. So today, one of the things I wanted to, Marcus, you could just get to the agenda page. Thanks. One of the things that I wanted to also do is provide opportunities for us to access our partners in government as well as our other stakeholder partners. So I want to have Rachel Thaxton talk about where we are with substance use disorder, viral hepatitis, and HIV. I know that's what your agenda says, something else, but if you could weave that in, Rachel, I'd appreciate, you know, off the fly.
Well, I have a PowerPoint. I don't know if I can share my screen if Marcus can make me the host for a minute. Yeah. And I am certainly not the expert on HIV and viral hepatitis, but I can do my best to weave that in. And then I did add a couple of slides at the end that the Bureau for Public Health were able to share with me. So let me see if I can share my screen.
And Rachel,
here.
First of all, let me say thank you for doing this. For those of you on the call who don't know, Bob Hansen is going to be retiring, and Rachel is going to be the one who, Bob, don't look crazy. Bob told me if I had a problem or issue that I should call you after he retires. I hope you know that. So now everybody else on this call is going to call you too.
That's perfectly fine. We're hoping that, oh, this is the wrong slide. Hold on a second. We're hoping that they name a new director soon. And when I say we, I mean me. I'm very, very, very hopeful that they're going to name someone as soon as possible. Okay, looks like I'm sharing now. Let's hope that this will go. Okay, can you all see this, just the slide?
Yep, perfect.
Okay, great. So you're not seeing all my crazy notes. That's good. Okay, so there's a lot of content in here, and so I'm going to do my best to kind of just slide through this and hopefully not take up your entire meeting. I just wanted to make sure I covered all the bases. And as you know, one of the things on the agenda that I'm supposed to be presenting on it is our substance use response plan, which is a 3-year plan. So it's fairly comprehensive, and there's a lot of content there. So I tried to pare it down to kind of just bring forward the major points. Something that we always start with when we're talking about substance use disorders and the Office of Drug Control Policy is the statistic here, which basically just shows us that West Virginia's rate of fatal overdoses is almost 3 times that of the rest of the country. So, you know, this is not new information. Everybody, I'm sure everybody on this call probably knows that West Virginia has the biggest problem when we're talking about in terms of the US and the world, pretty much. So there's a lot of factors that play into that. But I just want everybody to be aware of kind of where we stand and why the legislature and the governor's office felt it so important to create an office like the one that I get to work in. This is an old slide, but we've just updated it. So I thought it was important to share it too, because it does have the 2019 data there at the end. And so you can kind of look at data over time from 2001 through 2019, just to see kind of how the drug epidemic has progressed in the state of West Virginia. As you can see in 2017, it's our biggest spike. And you'll see on the next slide that the Office of Drug Control Policy was created in 2017. So really it was in response to these numbers that they created our office to sort of coordinate all of the state's activities surrounding substance use disorders, prevention, treatment, and recovery. And
hey, Rachel, can I ask a question? I'm
sure.
sorry.
I'm
I'm taking moderator's privilege.
Anytime.
So what, can you talk to us about what caused the spike in 2017? Was there, was fentanyl bigger or something right there, or?
Yes, so that's really when we see the appearance of fentanyl being included in heroin and some other substances. So we've had some other spikes, I mean, in relation to the numbers around it. So we see a little bit of a spike kind of in 2012, and that's when prescription pills were really popular, and people, you know, West Virginia was being pumped full of those for years. And that's sort of the result of that spike. But then things kind of level off there, but slowly and gradually start to build up again. And that's due to an increased use in heroin. And then fentanyl in 2017 started really making its appearance. So yes, that is why I believe we started seeing that huge spike. And once we got there, I mean, the state really, you know, kind of snapped it together and decided that we really got to kind of address this on a coordinated front. And that's why there's a couple of years, 2018 and 2019, we see a decline, which is great and wonderful, and that's exactly what we want to see. But of course, you know, it's not good enough. It's still significantly higher than many, many years before. So, and really, even one death is nonsensical and not okay for us. You know, it's just not good enough. So we had planned and anticipated on seeing another decrease this year, moving into next year. But now with the occurrence of COVID and some of the social factors, we've seen some spikes and overdoses in the past few months that have been alarming and that we've taken action on. So we probably will not see a decrease in the 2020 numbers. But those are things that because of what we've done, some of the things that we've developed over the past couple of years, we were immediately aware of and were able to take action and engage the counties and communities that are seeing the highest spikes. And I also just, when we're looking at this slide, this is really not to make anybody depressed further, but this really only captures the amount of people who are experiencing a fatal overdose. So this really doesn't even capture the people in West Virginia who are just experiencing a substance use disorder. And those numbers are actually much, much higher. So the Office of Drug Control Policy, again, that's where I work. House Bill 2620 created this office, and it was passed in 2017, basically in response to that spike that you saw. And there was a plan that was developed and enacted in 2016, and they really wanted to see one body kind of coordinate that plan. And so that's where the Office of Drug Control Policy originated. It leads the statewide response to SUD crisis. We've developed strategies related to prevention, treatment, and recovery. One of our primary focuses is obviously the reduction of fatal overdoses in West Virginia. The Governor's Council was created in 2018. The Governor's Council on Substance Abuse Prevention and Treatment. They're tasked with providing administrative support and resources. And the Office of Drug Control Policy works very closely with the Governor's Council. The council acts as an advisory group to the Office of Drug Control Policy in the ongoing efforts. And it's a large council, so there's about 25 people who are actually on the council, but the subcommittees are actually much larger. We have a lot of subject matter experts who have agreed to work with our Governor's Council, which is amazing. A lot of great minds and people who are really passionate about seeing the substance use disorder epidemic in West Virginia reduced. So with the subcommittees, this group of people is comprised of more than 70 members. There's representatives from public, private, academic, nonprofit sectors, some even just really interested and involved community members. And you can kind of see the list of organizations that are represented, and I'll tell you that's just a small sample size of the people who are really involved. So the Governor's Council was created in December of 2018, and that kind of coincided with the appointment of our director for the Office of Drug Control Policy. Now, the Office of Drug Control Policy was around before that, but historically had not had a long-term director. All of the directors before Bob had come in and gone within 4 months of being there. So there really was no consistency to the office. And so, you know, establishing the council and appointing Bob and really having that consistency and cohesiveness, I think helped things so much. I mean, we were able to gain a lot of momentum that we're still working on. A lot of those projects and programs we're still working on now, and so much has been done. You can kind of see the work of the council to date, the appointment of Bob and Brian. The meeting started in January, right when Bob was appointed, right after the creation of that council. And one of the first things that the council really started working on was something that I'm actually here to talk to you about today, was the substance use response plan. And that process really was a long process because we wanted to be all inclusive and make sure that if we're going to have a 3-year plan, that it's comprehensive and that we're really touching on all the different factors that contribute to substance use disorders and how we can support people in recovery. So there were many, many meetings, several drafts of this strategic plan. They presented the plan to legislators, they presented it to the governor's office, and it was accepted and approved and published. right before the start of 2020. And we've already done quarterly reporting, which I'll talk about, and we're in the middle of planning for year 2. So we're actually getting ready to start year 2.
So Rachel, I'm gonna jump in again.
Yeah.
And so that this can be a little more interactive. And so here's my question for you. So for people on the call, like how would they, I know you've got the report, the plan, the 3-year plan is out and it's out in the field, but how do people, like the groups on here, how would they engage with the Governor's Council, or how would they engage with your office? How do they say, hey, actually, this isn't working? You have in your report that says that green knee socks is what everybody should have. But the truth of the matter is that, the polka dot knee sock is the thing. How do they say, this is what's happening in my community, or, we need to get access to that Governor's Council, or we need to talk to you, or, we need prevention services, or how do they engage in all of this, right? And I don't mean, and I apologize. So everybody, please know I am actually putting Rachel on the spot, but would have done the exact same thing to Bob.
No, you're fine. And I have, thankfully I have an answer to that question. I'm going to go back a little bit. So at the beginning, when we were putting this plan together, we did have a public comment period. And I know that sounds how that sounds. So let me be more thorough. We actually went out to all the different regions in the state and invited people from the communities and providers and recovery residents, operators, and any people in recovery. We asked them to come out and review the plan with us step by step. And we took about 2 hours and walked through it and asked people, do you think this is a good idea? If you don't, why? And what can we do to improve it? Does it need to be taken out? What are we missing? That's really where we wanted to focus on, is what are we missing? Because even with 70 people working on something, we get focused in and we kind of, lose sight of things sometimes. So we were able to do that. We ended up having 8 of those meetings at the beginning. We went to each of the 6 regions of West Virginia, and then we had 2 separate meetings for people with lived experience before. Then, even then, since though we have a process for making changes to the plan, obviously, and as you know, Tony, Bob is always extremely responsive. So if you send anybody in our office or you message our info page, that actually comes directly to me and to Dora, who is his administrative assistant. And we send those directly to Bob, and he usually responds himself. You can request a meeting with Bob or anyone in our office. We are always available. And I think that's something that people don't expect usually from a state agency sometimes. It's harder, they're large, it's hard to get to the right person, but our office really only has 6 people in it. So we're small and we're very, very accessible. So if you have any questions about the plan, let's say you go to our website, the West Virginia Office of Drug Control Policy website, which is, the link will be at the end of this. And you go to this report and you look through it and you say, this doesn't make sense, or you're not doing this. Send me an email. We want that feedback. I mean, this isn't something where we're like, oh, we're all knowing, we got it all right, don't bother. This is something that we know is going to evolve over time. Again, 3 years is a long time. There's no way we can predict what's going to happen in the next now 2 years. And we know that there's going to be changes. So with the first year coming to a close and year 2 getting ready to start, we'll actually be going around the state again in November and December, talking about our year 2 plan. So talking about what was accomplished in year 1, what we expect to accomplish in year 2, and again, asking for feedback from people And another place you can get information is the Governor's Council. So if you need access to the Governor's Council, again, that can be done through myself, through Dora, or through the info email for Office of Drug Control Policy, which is all going to be at the end of this and the contact information. So feel free to reach out to me. I'm happy to pass the message along. I don't care to be the middleman.
And if you'll give us the slides at the end, we'll make sure that everyone gets them along with those email addresses in a follow-up email. And I didn't want to put you on the spot, but I really also want to speak to the accessibility of your office, because I think people often don't know that they can send an email, they can call or write an email or say, hey, I don't think this is how this is going, and actually engage in some conversation. Stephanie, I'm waiting for what you want to say, because I've been looking at your face. I don't know you, but I've just been looking at your face, and I know you have a question. Go ahead.
I do. Thank you so much. So first of all, I'll just say briefly, my name is Stephanie Lancaster. I am the Director of Community Health Solutions for Emergent Biosolutions. We're the company that manufactures and sells Narcan nasal spray.
Ah, okay.
I have the privilege
Join the meeting.
Serving the state of West Virginia along with Ohio and Indiana. My question, Rachel, is kind of along the same lines. Can you speak to the subcommittees that you guys have under the Governor's Council, and kind of, I sit on those committees in both Indiana and Ohio for different county level agencies, but would love to get more involved with you all. I'm really sad to hear about Bob. I just texted Dr. Ackery, like, you didn't tell me Bob was retiring next year from somebody else. Ma! That's horrible, but I'm sure that they'll name someone just as fabulous. So I'm gonna be cool. But yeah, Rachel, if you could speak a little to your subcommittees that you've got active, that would be awesome.
Yeah, sure. So I have a slide up here, and we kind of talked about all of this, but down here it says the 7 areas of focus. So for each area of focus in the strategic plan, there is a subcommittee for the Governor's Council, except for stigma. Stigma is a separate work group that was developed by our office outside of the Governor's Council, which I know can be a little bit confusing, but there's also a work group, so you can join that too. So for the 7 areas of focus are, you can see prevention, community engagement and supports, health systems, treatment, recovery and research, search, court systems, or justice involved populations, law enforcement, and again, there's stigma, which technically is not a Governor's Council subcommittee, but still we felt important enough to be a separate area of focus in this plan. And so I'm going to run through these quickly, because I could, like, again, I could spend 2 days on the plan, or 2 hours, you all know that. But I'm going to try to go through kind of what these subcommittees are focused on. And if something interests you, I don't make the approvals for people to be on subcommittees, but I've never heard them say, no, you can't participate or anything like that. So of course you can say, send me an email and say, I really am interested in being a part of the health system subcommittee, or I have information to offer, or I have some ideas, and I'd be happy to pass that request along. There we go. So prevention in the strategic plan has 2 overall goals. Now, I know that you're probably thinking, well, that's not very much. But within those goals, there are several strategies and then key performance indicators or tactics. So all in all, there's probably 30 to 40 action steps within those. I just didn't want to inundate you with all that information. So these are just the overall very broad goals in this section. And there are 2. One is to prevent substance use disorder and enhance resiliency. So that includes implementing programs and frameworks that promote prevention and resiliency, things that address stigma through exposure to evidence-based programs. It also includes reducing adverse childhood experiences. West Virginia has to address and reduce circumstances that lead to substance use disorder, such as the ACEs. But we also have to improve the social determinants of health to improve wellness in our future. So that's kind of where this group comes in too. I mean, we know that hepatitis C and HIV also play a major role in the health and wellness of people with substance use disorder. Prevention will require statewide participation from public, private, state, and local partners. So, and then goal 2 is to monitor opioid prescriptions and distribution. So that's something that we're working on, ensuring the health professionals have training and knowledge in substance use disorders so that we can reduce inappropriate prescribing for pain. And then also conducting public health surveillance using the PDMP or the Prescription Drug Monitoring Program and making sure there are guidelines associated with that. So that's kind of where we are in prevention. Again, that's definitely not everything that's happening, but those are the overarching goals, and some things have progressed and we're still working on others. Another area of focus is community engagement and support. This is where I spend a lot of my time. There's 4 goals here, and this is a really big section. So if you open this up, this one's going to be a few pages long because it includes some of the bigger issues and universal barriers associated with receiving help all over the country, and especially in West Virginia. So increasing capacity of recovery housing. So this is a huge goal. We know that housing, affordable, safe, sober, recovery-related housing is important for people. If they're going to be successful, that they have somewhere safe to be after they've completed a recovery program or a treatment program. This really becomes a very important issue. Transportation in West Virginia. I know that everybody on this call has probably run into an issue with transportation. So really exploring what the problems are, where the gaps are, and what we're going to do to fill those gaps. And really identifying what we've already got and making that available to everyone in West Virginia, because we have some really great transportation programs that are filling some of the gaps, but not everybody knows about them. So there are a lot of goals and tactics and action steps we're taking with transportation. And one of those is just to research innovative models from across the nation and see, will it work in West Virginia and how do we make it happen? Goal 3 is to increase employment opportunities for people. Again, this is a really large section of the plan, but some of the things that fall within that goal are supporting businesses who want to become recovery-friendly businesses and offering them the training and the knowledge and the support to do so. Increasing recovery-owned and operated businesses in West Virginia, social enterprises, things like that, and just reducing those barriers that people run into when they're trying to become employed after they've gone through a program again. And then the 4th part of this is helping communities become organized when they're looking at their community as a whole. So if I'm in the Kanawha County area and I'm trying to figure out what Kanawha County needs because I want to help, I need to be able to go to a place and say, what do we need? And I can look and see that, oh, okay, we're really lacking in the prevention department. That's where I really need to focus my area, my interests, because we want to see that full continuum of care in every part of the state. A lot of parts of the state have a lot of prevention and a lot of recovery supports, but no treatment or no recovery housing. And so we're really trying to look at that full continuum and then make that information available to people in an intuitive way. Health systems, 3 goals: reduce fatal and non-fatal overdoses. That's a given. We want to be able to expand access to naloxone, and I'm going to talk real briefly about what we're doing with naloxone, expand quick response teams, utilize the data that's coming in to make quick adjustments and engage communities, kind of like I talked about in the beginning. Goal 2, expand points of access to treatment through the healthcare system integration. So how do we get treatment on demand? How do we make sure if a person goes into the emergency room for a substance use disorder, that they get from the emergency room to the next step in their treatment plan? How do we create that continuity of care? And then also reduce risk of infectious diseases associated with substance use disorder. So I think that's where you all are focused, where this group's primary focus is. So, you know, some of the strategies that you can see under this goal are to increase the understanding of harm reduction and stigma, increase cross-sector partnerships in the design, implementation, and evaluation of comprehensive evidence-based harm reduction programs. So basically, are we communicating? Are we working together? Are we doing testing on our end? And then on your end, if you're doing testing, are you then making referrals? How are we crossing over into each other's different areas of expertise, not to take over, not to do it, but to make sure that both of us know what the other is doing. Another strategy is to increase screening for and rapid access to treatment of infectious diseases associated with substance use disorders at any entry point for substance use disorder treatment. So every entry point should have that screening available, and that's something that we are making a priority.
Right. So, Rach, I have two questions for you. One came from a Facebook group. It said, how much participation did you have when you reached out to folks in recovery to get feedback?
Mm-hmm.
And then I have a question of, where's the money to pay for all of this? And how do we on this call access that money to implement these programs in collaboration with DHHR?
Okay, so first I'll answer the Facebook group question. So we did 2 lived experience meetings, one in the northern part of the state and one in the southern part of the state. And we had pretty good engagement, although obviously not what I would have liked to have seen. We had about 40 people come to the one in the northern part, because I helped facilitate that, as well as Matt Boggs, who is the chairman of a couple of the subcommittees, and he's also on the Governors Council and in recovery himself, as am I. And we had more people in the southern part of the state, probably about 50 show up. So I would have liked to have seen more, but that was not the last time that they were able to give feedback. In fact, I'll tell you this, we've just added another subcommittee to the Governors Council, which is the recovery subcommittee. So we've asked people who have lived experience with a substance use disorder, who are now in recovery, who represent multiple pathways and from all over the state, each of the regions, to convene for a subcommittee. And our first meeting is actually tonight, to offer their feedback and to be representatives from their regions to speak for other people in their area. Because really, I mean, people in recovery, we know what works. You know, we've been there, done that, and some of these ideas that a lot of times people have are great ideas, but in theory, but in practice, sometimes we know that what's going to really happen when people are going through that process. So we are working.
You said you said the meeting's tonight somewhere?
Yes.
Where?
Well, that's the recovery subcommittee. So it's happening through Zoom, and it's our first meeting. So it's just going to be those members that we've started with.
Okay.
And then I don't know what will happen from there. I know that the committee is not completely full.
Okay. If people are interested in joining in the future, can they send you an email, or should they send me an email, or should they send Amy Snodgrass an email?
They can send me an email. And as we work on different things, like for the strategic plan, we'll be able to join in people who are not actually members of the subcommittee. And I think all the the meetings are public anyways. So, but yes, that is tonight. So we're really excited about that. We're excited that the Governor's Council and obviously Bob think it's important to have people with lived experience offer their insight. I mean, I think that's a big deal. For a long time, you know, decisions have been made by people who have not experienced it. Not that they're bad decisions or anything of that nature, but I think there's some valuable insight there and feedback that we'll be able to gain. And it's great that they think it's important. The other question you had was about funding, and I'll tell you, we've actually costed the entire plan. So our accountant and all the fiscal people who are not me ever have gone through each of, not the goals, not the strategies, but each of the KPIs, so the key performance indicators, which are all of these things broken down into smaller parts, and said, who's going to pay for it? Where's it going to come from? Do we need money for it? And so we have that all costed out. We've been doing that over the course of the last year as well, as we've been working on things. And so that is all taken care of. A lot of the funding, a lot of these things are things that we can pay for with SOAR dollars. So the state opioid response funding that's come in. Some of these things have been started and they're a continuation or expansion of what's already happening. There's block grant funding, there's COSAP, I mean, we have lots of federal grants that come into our state. And it's really just seeing, you know, what was already available and what other entities can we partner with who are already doing some of these things. Like, for instance, in the employment piece, Jobs and Hope.
I'm asking in a way, Rachel, and I'm sorry that I'm interrupting, but I want to make sure I'm trying to get the questions I think are maybe on people's minds, which is, okay, that's the money that's coming to the state, but let's say, I don't know, I'm not gonna pick on anybody else because I already picked on Stephanie and I already picked on Amy Snodgrass. So let's say CEG, I'll make it us, wanted to partner and do some support services. We wanted to do Naloxone distribution. I mean, for example, I know that there was that harm reduction grant that went out a month ago, but in other jurisdictions, there would be like an annual RFP that would go out for community-based organizations to work and to do the service work. I mean, how do these organizations partner with you? How do MAT clinics, which may be providing medically assisted treatment services and want to do that linkage on infectious disease, how do they get a grant to provide community services? Can they? Do they? I don't know, and I don't mean to put you on the spot, but I'm sure a couple of people are sitting here thinking a great plan, but we all got to figure out how to do our piece too. And how do we get money to do it?
So there should already be several AFAs that have gone out over the past year and that will be coming out this year. I know of some even coming out this month. So as we push things forward and see the needs and where they are, you should be seeing an announcement of funding opportunities coming from the state level. If you're not signed up to get those emails, again, you can sign up on the DHHR website, but those usually get pushed out by the Bureau for Behavioral Health. Most of the things concerning substance use disorder are pushed out by the Bureau for Behavioral Health, although if it was a harm reduction grant, those come from the Bureau for Public Health. Typically, the state is going to ask for what they need, ask for what we want. So we're going to put out a grant for recovery residences, and we're going to say they got to be multiple pathways, and there are some things that we want to incorporate that are really going to touch on many parts of the plan. A lot of times, you know, you just need to be looking for those and thinking about how what you want to do fits into that, and who you can partner with to really make a huge difference in your area. But if you feel like there's something that we're not asking for. So you're in the community, you see it in the plan and you're wondering why you haven't seen an announcement for funding. Send me a message and ask me, because I mean, I can find out for you. I don't have all the answers for all the funding questions, but I do know that the state typically asks for what it is we want. And we're pretty specific about it usually, but a lot of times, you know, we don't see everything and we are, again, open for suggestions.
Okay.
Or we can also make funding suggestions.
I knew people were like, okay, how do we pay for this?
Yeah.
How do we implement this plan on our end? That's what the health department is saying it's going to do. But, you know, there's a burden that gets placed on organizations too. And like I say, I come from the philosophy, none of us can do this alone. So we have to do this in concert with organizations that are providing MAT services, HIV, hepatitis, harm reduction, for-profit corporations like Stephanie's, the health department, federal, state. So I'm like, okay, all right, this is what the plan is. Sounds like a good plan. How do we pay for this plan on your end? But how do we get money for what we're going to have to do for this plan too, as your community partners?
So I think another thing is a lot of people come to us and say, we want to do this, we want to partner with so-and-so, and we know who has the money for that typically, and we can connect you with them. Because a lot of people have state funding or grants, and then they subcontract with other people, or all of our funding that comes in, we basically get the funding and then put it out for other people to do. And so we want to connect you with someone so we can get the job done, and obviously you can get reimbursed for your services. Bob was great at that. That was one of his, because he knows every single person in West Virginia somehow. So, you know, he was great for that. But again, he'll have a replacement soon, and I'm sure that person will be equally as great. And if not, I'll call Bob and ask him myself. We'll make the connections. That's something that's great for us to do. I mean, it really kills two birds with one stone if we can connect you with an entity that needs the services,
right,
and has the funding.
Right, and like I say, and this is, you know, what I'm hoping that these calls are once a month, or where people are getting information, where we're learning where to get the information, and then so that everyone on these calls can do with their jobs better, right? Can help their communities better, and get more tools to do that. So thank you. I don't want you to feel like I don't want to put you on the spot, but I know as people are going to ask, and they're going to say, well, she didn't tell us where to get the money from.
Bob, get it from Bob.
I'll text him that right now.
No, you're fine, Tony. I'm telling you, again, you know, I've worked with Bob, so this is basically my everyday life. So please ask away. I want to be helpful. You know, I don't have all the answers. I can't, you know, without drilling it down to specific issues, it's hard to answer it with just a general overarching solution, but I'll tell you, we'll get there. I'll get there. So again, you know, if you think there's something happening and you want to be a part of it, or you don't think it's being funded already, reach out and we'll figure it out.
Okay.
Yeah.
Perfect. I'll let you wrap up.
Okay.
Okay.
I'll go quick. You just, you know, do the like cut thing when you just want me to stop. I'll try to get through the rest of the subcommittees, and I'll just do quick. So you can get this offline too. So I'll just glance over these. So there's treatment, recovery, and research, which is also a very large section of the plan with the 4 goals you see there. So improve effective treatment in outpatient and residential facilities. Again, we're trying to lift up that continuum of care and make sure that we have a step down process for people, so they don't just go from intensive inpatient to home. And there's some steps in between there to support them. We know that engaging people for as long as possible is more effective. Increase health professional workforce to treat people with substance use disorders. So that's been a pervasive issue for many years. How do we retain the workforce? recovery supports, and then conducting the relevant research and evaluation, and then disseminating that information to make sure that we're being effective. Court systems and justice involved population. This is a huge piece, in my opinion, on reducing the number of fatal overdoses in West Virginia. We know that a large portion of those overdoses in many states are people who have been associated with the criminal justice system or released from jail or prison in the past 6 months. People, have been incarcerated and have not had access to any substances, and then they leave and they have access again, and it has a fatal result. So providing access to effective treatment for individuals with substance use disorders in the criminal justice system is important, but then also making sure they have the supports that they need upon re-entry is a really, really big part of that. So 2 really important things there, with lots of steps that go into it. Again, you'll have to check out that plan. Law enforcement, expanding law enforcement to treatment and recovery, so diversionary programs like law enforcement assisted diversion, giving law enforcement the tools, and then, sorry, I hit the wrong button, and then equipping them to respond to overdoses. So working on stigma, working on making sure they have Narcan and Naloxone available to them. I don't want to take up a whole bunch of time, Tony. I have a lot of information. So this is information about the quarterly progress reports, which you can also find on our website. It'll walk you through Q1, Q2. We're getting ready to publish Q3, and obviously the end of this year will be the year-end report. I will, however, I'll skip this part because I wanted to touch on the naloxone distribution in the state. As some of you may know, and Tony talked about it, the naloxone day we had in Kanawha and Putnam counties was made possible due to House Bill 4102, which relaxed the guidelines for distributing naloxone in the state of West Virginia. So it allows individuals to distribute naloxone under a standing order. So we partnered with the University of Charleston, the Bureau for Behavioral Health, and started making naloxone widely available to providers, especially at the beginning of COVID. We started before then, but when COVID hit, I spent weeks emailing and calling personally, QRT teams, crisis stabilization units, residential treatment facilities, harm reduction programs, high volume MAT providers, homeless outreach agencies, making sure that they all had naloxone on hand, so that when they left a patient or the patient left their care, they could leave naloxone with that person. Because again, just like with the criminal justice system, when people leave treatment or recovery or haven't used in a certain amount of time, a prolonged amount of time, and they return to use, I mean, they are at such a high risk, and we wanted to make sure that people had access to naloxone, because the one thing that we know for sure is that we can't help anybody if they are not alive. So that became a really huge priority, and that kind of fed into the Save a Life Naloxone Day that Tony brought up earlier, and I know you were asking about funding. And we coordinated this. We did not fund this. We didn't actually fund this day, but we helped work with the community and the other programs and organizations to offer up resources. And they were able to get funding through community partners like the Greater Kanawha Valley Foundation and CAMC Foundation. And we were able to help make suggestions on where they might be able to get that funding, and it all worked out beautifully, and we're willing to do that anywhere. They're starting to work on one in Cabell County now, and we have all the resources still on our website. You can go to the Save a Life Day and see kind of like all the outline of what we did, and if you want to access anything like volunteer sign-up sheets or marketing materials or see where all of our sites were, how the volunteers were organized, you can kind of go there and see how that was all set up. And we're happy to help any community plan a day like that. You can see it was a huge success in just those 2 counties. There were 17 sites, 150 volunteers, and over 1,000 kits distributed. So we were really happy with how that turned out. Again, some other things, the data dashboard, which is on our website, this displays overdose data in a really timely fashion. It was being updated every 2 weeks. So you could almost get it in real time, but not quite there yet, but we're trying to push it to the limit there. And with COVID hitting, I know we hit a few snags, but this is available. So if you need overdose data for grant submissions or anything else, you can go there to get it. We implemented an app for people in recovery at the beginning of COVID to help them sustain healthy connections with their treatment providers and with each other and with peer recovery support specialists. I'm trying to go really fast. So hopefully, I know I'm going really fast over this stuff, but again, if you have questions, ask me at the end. But this is available for free for every West Virginian. If you don't know about it, please ask me about it, and I will connect you to the Connections app. Atlas, which is a treatment program quality indicator website. This kind of lists all the treatment providers in West Virginia or the ones who wanted to participate, and talks about what services they offer, and you can go there and see if they're a quality provider, if they're giving appropriate care for what you are looking for in a substance use disorder treatment provider. That's also on our website, and the link is there, and I will share these slides with Tony. Treatment and Recovery Resource Map, which is also on our website. You can go on there and search for resources by county, program type, ASAM level, gender. All the recovery residences that we know of in West Virginia are there, treatment providers, MAT, moms and babies, all the things that you might need to know when you're looking for a treatment program near you is there with contact information. So you can look at the program, see what it's about, check it out on Atlas to see if it's quality or quality that you're looking for, and then you can call it. So, you know, that takes care of a lot of issues that we know of in the past. I'm going to stop there because I just know that I've been talking your ear off, and I'm going to go.
Rachel,
Yes.
First of all, I want to thank you. I want to thank you also for being a good sport, for me jumping in and asking questions. But again, I'm trying to, you know, with COVID, with this being Zoom, I wanted to also figure out how we always make this as interactive as possible. You know, I know you had your slides, so I thank you. For your
I'm glad. Thank you, Tony.
Presentation, but I also want to try and get questions in there for people. And here's your contact information. Good. You're smart. You didn't put a phone number.
Dora did that. Thank you, Dora. I can put it on there. I'm not afraid.
You're not slow. You're like, here, take all the email addresses you want.
I'm extremely responsive.
But again, thank you. If anybody has a question for Rachel right now, feel free to put it in the chat and I'll ask it. But again, I really want to thank you. I want to thank your office for everything that you do in the state. And we look forward to your continued support and to continue to work with you.
Okay, I'm going to put that contact information in the chat just in case you didn't get it and you need it.
Right.
So I can turn the screen back over.
I would not put my telephone number there, but that's just me. So, you know, Stephanie, I don't know if you know, but we're probably going to ask you to present on the next call because okay. It says, hey, Rachel, are you able to share your slides with us after this meeting? Yes, we are. We're going to send them out to everybody who's registered for this. We'll send the slide deck out to everyone from our end, and should be able to get that out before week's end. And next up, I think, is Brooke. Are you up next? Yep. All right, Brooke, on to you. You're the next one.
All right. I'm Brooke Parker. I'm a social worker here in Charleston with the Ryan White program, and I am also a community organizer with SOARWV, Solutions Oriented Addiction Response, and we provide the only mobile street outreach harm reduction program in Kanawha County. So that's what we do, and I think I'm talking today about HIV and access to testing, right?
Hopefully. But whatever you want. Hey, look, you got like 30 people on here. Talk about whatever you want.
So I know a lot of it too was how COVID has affected the people that we serve, and so just as for a little bit of background, because I don't know a lot of people on the call. We see about 250, 300 people twice a month. We take safer use kits out to the community, and so we're a grassroots group. Right now we're self-funded, all volunteer, and that's what we started out as, a very small, just a community-based grassroots group advocating for people with lived experience, people who use drugs, and it turned into something with the pandemic that we never would have imagined. Before the pandemic, it was a new thing for us to take out safer use kits. We were honestly
what's in your safer use kits? Can you tell the people what are in those kits? Because they might think that you're giving people a piece of juicy fruit and a bus.
We do that too. We have food, we have water, and snacks and supplies. Like in the winter, we try to keep gloves and coats and hats and pocket warmers, because a lot of the people that we serve are unhoused, or they're living in abandoned buildings, they're in encampments. That's the majority of people that we serve. They're people that don't otherwise see care providers. They don't see anyone, they're not in any type of care. So we, safer use kits is clean injection equipment. That's the majority of what we distribute is just safer injection equipment. We try to keep people supplied as best as we can with the safer use kit. Would include sterile syringes, antibiotics, naloxone. We use, well, for our street outreach, we use IM naloxone. Of course, we provide training to anyone who doesn't know how to use it, and Band-Aids, antibiotic ointment, ties, cookers, any kind of everything that you would imagine would need to go into a harm reduction kit, because there is one syringe service program in Kanawha County. It's in Charleston. It's very small. It's a very high barrier program, and most of the people that we see they can't use it, or they don't use it, and it's not accessible to them. So that's what we do. Part of our street outreach expansion when the pandemic hit, what we saw happening was resources were so hard to access before the pandemic, when everything was open, people could get the places they needed to go. It wasn't as difficult. It's still amazingly difficult, but not terrible. And when the pandemic hit, we saw such just so many barriers come up for people. They couldn't get anywhere.
Barriers like what? Like what? What do you mean, Brooke?
So barriers meaning access to providers, access to medical care, access to even just safe use supplies, access to wound care was a big one for us. We saw people that, maybe previously they were getting some care, they go to the ER, kind of tolerate what would happen to them in the ER. But when the pandemic hit, it changed a lot. And we saw people showing up with wounds that we weren't used to seeing before the pandemic started. They were getting care somewhere else.
So before the pandemic, how many kits did you go through in a week? And then after the pandemic, how many did you go through in a week? I just want to give people some idea of scale.
No, absolutely. So pre-pandemic, we were distributing naloxone and safe for use kits weekly. We were going out every single week. We were packing maybe 20 kits. Then it turned into 40 kits. And now we're at between 250 and 300 kits every 2 weeks.
So quadruple. So yeah, quadruple. Okay.
It felt like it happened overnight. We were hearing about an average of like 12 overdose reversals a month. So every week we would go out, collectively it would be 12 overdose reversals a month that we were hearing back about from naloxone that we had distributed. And when the pandemic hit, it's increased to an average of 72 reversals a week. So it went from 12 a month to 72 a week. So by our calculations, we've seen like a 400% increase in overdoses just since the pandemic started. And I know a big thing that we saw too, we think that some of this is, it speaks to a need for better education about naloxone use and how to properly use it. But the reports that we're getting back from our people that use naloxone is that it's taking 2 and 3 and 4 and 5 doses to reverse an overdose. And even then, they still need to, they still call 911 and an ambulance still comes and with more naloxone. We do think that after talking with a lot of people, we do think that they need more training and just a little more, just more training on how to use IM naloxone in particular, waiting a little bit longer.
IM, you mean intramuscular?
Sorry, intramuscular. It's cheaper than nasal Narcan. It's the cheapest that we can provide. It comes in a little vial. And so we give, that's what we give out. That's what we can afford, so.
So I want to ask a couple of questions, and I don't mean to put you on the spot, but you saw what happened to Rachel. So you kind of knew what to expect.
I knew what to expect.
And anybody who's gonna like be a presenter on future calls, now you know kind of how this is gonna roll. And again, because I think it's important that we know who our community partners are and who our community allies are. And I think that the work that SOAR does is really, really important, right? And so I have a couple of questions for you because I got to get my needs met here too. How many HIV tests do you do? Are you linking folks to HIV care? And then my other big question for you is that you said that you guys are volunteer led and run and don't have a ton of dough, it sounds like to me. Doesn't sound like y'all are down there making it rain naloxone. But what can people on this call do, right? How could we help support SOAR and the efforts of SOAR? Is it a financial contribution? Should I buy 100 pairs of socks and send them to you? Should I buy 1,000 doses of naloxone from Stephanie at a big fat discount that she's gonna get me? A big, huge discount, huge, not just big, huge discount she's gonna get and ship that to you. Should we get doctors who may know you? Should we get some training for people who, so there you go. There's my really long-winded question.
Got you. I expected this. I totally expected this. So I'm prepared completely. I guess we had not even considered, before the pandemic, we had not even considered anything beyond. We were running around, honestly, just to places where we knew the people were congregating and just asking them if they needed safer supplies. We hung out, building relationships with people and just knowing how important it is to invest and build relationships and earn the trust of people. So that was the intention that we had started with. And then when the pandemic hit, and we went from running around with those 20 kits and struggling to get rid of them to needing to pack 250 kits every 2 weeks with 2 weeks worth of supplies in each kit. And even then it's not enough. You know, we have 40 syringes in each kit because that's what we can afford. We know that that's not near enough. We have sharps containers. We have a method now for collecting needles to come back, and we dispose of them so people don't have to carry them around with them. And but what we saw happening was just if the level of care was insufficient before the pandemic hit, it got exponentially worse after the pandemic. And so I had started talking with Dr. Teague, from the Ryan White program, and we made arrangements for them to come out and see how a street outreach went. And before we knew it, we had doctors from around the community and from the Ryan White program coming to set up and do testing and wound care. There were nurses that were coming to volunteer their time helping to do wound care, because before it was a couple of us with first aid kits doing kind of the best we could in parking lots, because that's what we knew to do. And in talking with partners throughout Southern West Virginia, like I think I saw Lil on here, and Lawson is in here. Knowing the community that we serve and being on the ground with people that don't have regular access to care, it's just not going to a clinic or going to a hospital, having a regular provider isn't possible for them. I think we just decided to meet the need and go to where people, just to go to where they are. So
what can people give you?
Money and anything. I mean, honestly, like we can use, we have a sustaining donor campaign that we just started working on, where you can send us money. $9 buys a kit for someone in Kanawha County. When we have extra, then we always try to share with. Can
you put the link in the chat box?
Absolutely will.
So I think, and we'll send it out in the email also. I'm sorry, I didn't mean to jump on you, but I want to make sure that, yeah, I want to make sure people get this and I'm challenging everybody on this call. She said it was $9 a kit per person. Listen, I see some Gilead people on there. They make good money. Yeah, I said it. I'm saying y'all can buy 10 kits individually from your personal money. You're not traveling to pay your commuter to work. You can buy 10 kits. That's $100. So all of the Gilead people on here, I'm challenging you to $100. I'm gonna commit to $100 out of my pocket. Trina, Jared, I see who else I see. Sherry, why Sherry jump off the phone? Sherry, $100 from my Gilead people, at least from as a personal contribution. Stephanie already wrote her check, so I'm not even worried about. She writing her check now. Look at it. She's like, I'm scribbling my check out now. The link is in the put the link in the.
I will. I'll drop it in there, definitely.
And so there you go. Hopefully, I just got you at least $500 at least.
It's useful. The biggest things I think that, like when we're talking about the outreach that we do down here and that our partners do, we see a huge need for just people being able, like the transportation issue, I think that Rachel had kind of referenced also. People can't get to where they need to go for infectious disease treatment. When we can get them tested, the barriers that come up are that they don't have a way to go get treatment. They can't stay engaged in treatment. They can't get the care that they need. So especially in like less populated counties, the referral sources for people who are testing positive, they're limited. They have to travel a really long way for treatment. And for people that don't have access to transportation, they don't have access to a phone, they don't have access to the internet, they don't have when they don't have those things, it's gonna be impossible. So mobile outreach from our perspective is gonna be the way that we can really step in and make a difference in the communities that we're serving.
Brooke, did you say you're in Kanawha County?
Yeah, we're in Kanawha. Mm-hmm.
And so that's the only county that you're in?
We're in Kanawha County right now. We have Lil is on here from Boone County, and right, Lil, Boone, pretty sure. And yeah, we have partners. Yes, yes. We're in Kanawha. It's limited down here. It's hard. Lil in Southern West Virginia harm reduction covers Boone. Lil, you're gonna have to correct me.
You said Boone and Raleigh counties.
Yeah, Boone and Raleigh. For
Okay.
now, we want to expand to Logan and Mingo and McDowell, but it's just not. We don't have the funding or the people at the moment.
And like, I know for us, it's easy. It's relatively easy in Charleston because it's very centralized. We have it's a higher population. It's not hard to get to where we usually set up. We've got a decent system for communicating with people over text and word of mouth. And look, we don't advertise. We definitely don't advertise. But the problems that we do run into is like outside of Kanawha County, outside of Charleston even. We've noticed we're starting to work on how to almost like do a census and figure out where people are coming from, because we're learning that people they're not just from Charleston. There's larger amounts of people that are coming in cars, and we've never seen them before. So we know that word of mouth is spreading, and that's exactly what we want. But understanding where people are coming from is like the next issue that we want to tackle.
Right. So you've got two questions. One is, do you have partners in Berkeley and Jefferson? And that's from Luann Kramer. And I think that she's trying to jump on the SOAR bandwagon. So I would jump all over that. Just don't let her tell you a joke, because her joke wasn't funny earlier. And then there's Jennifer is it Estevez or Escavez? I'm not sure which. It says,
Estevez. Estevez.
Estevez, see, you know, it says we operate an opioid response innovation initiative in Boone and Mingo and have just expanded to Lincoln and Logan counties. So,
y'all, awesome.
So I think the three of y'all should definitely probably get together and coordinate maybe with Logan and some other people that are in here. But I think that, so I guess for the three of you then, are you seeing expanded need or request for HIV, hepatitis C screening, linkages to care? What's kind of in that space?
I know for us in Charleston, when the Ryan White program came to work with us, it instantly became, it was like magic. I don't know what else to say. It was just total magic, because they show up, they bring all of their supplies, they bring all of their own staff. And the biggest thing that we struggle with is providing a private enough place, since we're operating out of parking lots and cars, just a private enough place for people to have confidential testing. That's the one thing we've run into that's really, really difficult. But as far as I know, there's no other consistent mobile outreach to other parts of Southern West Virginia as for HIV or hepatitis testing. I think after a positive test comes back, the barriers that I've learned about is testing has to be anonymous to get people into care, like going to the health department, and all of the struggle that comes with that is really difficult for people, and they don't want to do that. So anonymous testing has been a really, really strong thing for us to be part of and to advocate for. Having enough tests has been a real difficulty. I think the state needs to
Having access to enough rapid HIV tests or rapid Hep C tests? Is that what you're saying?
Mm-hmm. I know even with Ryan White program, other people that we've talked to, they'll show up and maybe there's 30 tests that they have that week, but there's 60 people that want to get tested. It's just awful to watch it. And then trying to get those people to come back a second time, or trying to figure out a way to get them to come just show up at a clinic or get them transportation to a clinic. We lose them really fast. If we can't offer it right there on the spot when we talk to them, it's been really difficult to catch them a second time.
Okay.
We have learned, most programs, from what I understand, can pay, like the $5 gift card if you stay for your results and get tested. It's been, when I talk to community providers, when I talk to people that participate in it, it's really nice to get the gift card. The concern that I'm understanding is that it's not always sustainable. Giving a gift card and paying for a test isn't going to be sustainable forever for communities. And then when testing comes around where there isn't a payment in exchange for the test, then it's I guess it's less enticing for people to stay for it. So incentivized HIV and Hep C testing has been working, but the challenge is, can you sustain an incentivized testing model? It's functional, it absolutely is, but is it sustainable? Is kind of, that's what we've really run into. We know that with as we're able to get testing through harm reduction programs, case management and the resources and the infrastructure to get and to keep people engaged in care is just beyond our control. It's beyond our capacity. So community agencies that have the capacity to do that, partnering with groups that have relationships with people, marginalized people that aren't coming into clinics, they're not showing up at the hospital, they're not engaged in any other kind of care, I think is going to be really key, especially in rural areas. Otherwise, they just don't see anyone.
So let me ask you, Brooke, if you get a Hep C or HIV reactive client, and I'm imagining that this is happening with these Ryan White providers, what's the continuum of care for them? How do you link them to care and treatment for HIV or viral hepatitis? I know I got a note here from Jeff. I know that they're going to talk in a minute about hepatitis, but I mean, I think that to me, in West Virginia, I feel like that's the nail on the head, right? What is the continuum of care? And it's county by county, town by town, kind of, given transportation and other issues.
I think for most, Lil and I talked a little bit about this, but giving people rides to Charleston is a lot of what they've been working on outside of Kanawha County, because you have to come to Charleston for treatment. So the not having centralized treatment makes it really difficult for people. Having to come all the way to Charleston for treatment is also really difficult. And the continuum of care that I understand is that after a rapid test, then you need a blood test. And then, so people would leave after a rapid test with a referral to the clinic with an appointment already set up for that next day, because we go out in the evenings. So then it just depends on that person being able to show up to the next one. And I think a lot of the times, what I've seen happen is that people will get a positive test, and then because of a million different reasons, they can't show up to that next day appointment, and then it gets overwhelming, and then it feels like an insurmountable thing to try to tackle by yourself.
So I guess I have a question, not for you, Brooke, believe it or not. And the people who know me are actually laughing hysterically, particularly Ms. Trina Scott, who is up shortly after you, so she should not laugh now. But at any rate, is there a transportation provider on this call? If so, can you ping us? So, I mean, what you highlight is Marcus, Emma, Amanda. I'm going to task you with getting in touch with who are the medical and non-medical transportation providers in West Virginia so that we can get them as a part of this conversation around need, right? They may not give us money, they may not give us the van that Brooke and them need, but I think we need, and Rachel says she knows some transportation options folks too. And so I think that, again, as we are shaping this conversation and having this conversation, I want to identify, who else do we need to be talking to? We need to be talking to some transportation providers, or we're going to put our money together that we just gave Brooke, and get it back and buy a van and go to the transportation business.
I know what we do, and Lil is saying, I think right now too, we use our personal cars to take people to appointments. If we know that that's what's happening Wednesday night when we go out and we know that they can get into the clinic that following morning, we just make arrangements to meet them and we just take them. And I know Lil does that a lot too. The Medicaid reimbursement with Logistic Care is that's a tool that we can use, but a lot of people, the majority of people that we're seeing, they don't have a fixed address, they don't have ID, and they don't have Medicaid. So the barriers that come up with that are getting people to that place where they can start working on getting their birth certificate and their social security card, so then they can get an ID.
Yeah. See, that's a lot like our CHAMPS model that we used in DC, where we trained individuals who had histories of incarceration, drug use, substance use disorder, to do the HIV screening, to do blood pressure measurement, but then would also pay for them to do the direct linkage to care and do the follow-up like 3 times after, right? Because that's the other piece. We can get you to that first screening, but can we get you there for the result? And if there's a need for you to have a primary care visit, can we get you to the primary care visit? I think often people think that it's just that one step of giving them the harm reduction kit and then the person is, but that's not really true. I mean, that's not, and nor is that truly harm reduction. I'm sorry, I didn't mean to take over your presentation, but again, it's my Zoom account.
True. I know we've talked a lot about expanding training opportunities for that testing certification. And I know SOAR it's a conversation that SOAR was involved in a little while ago. And I think it's come up a couple of times. And I think that's something that we just started talking about again, very seriously, to figure out how to make that happen. And I know I got to talk to you about that. We'll put a pin in it. The offering home testing and self-testing is another thing that we had been talking about a little bit, and that's a newer idea for us, but being able to send kits home with people, or send kits to people that we know might be interested in one, and having a method for getting that information out to them is something we've been talking about lately. And
yeah, we're putting out a decision tree of how you actually can do HIV or, pardon me, viral hepatitis screening in West Virginia, because so many people think that they can only do it if they go to the WVU training, et cetera. And that's not true. I mean, you can get your certificate that way, but you can actually add HIV and hepatitis C testing to your protocol of service without it. So Marcus just sent me a text telling me I only have 36 minutes left. So yeah, that's what happens when I talk too much. So Brooke, I'm gonna thank you I'm going to go for 10 minutes to the community liver council, and then the rest of the time will be for Gilead and the training program that we have, and 3 minutes for Marcus. Go, Jeff. You're on mute, but
okay. How's that?
Perfect.
Okay, hi everybody. Jeff Messerly with the Community Liver Alliance, and just a real quick backgrounder because I know I have no time because we've had too many jokes. Community Liver Alliance is headquartered in Pittsburgh, but do not hold that against us. I'm a WVU grad. I'm from Northern West Virginia, and Wheeling in particular, if you want to know where. But we work in Central Appalachia, and that was the vision of Judith Feinberg out of WVU, that this problem, this syndemic, it doesn't have state borders. So, you know, we've told Bob Hansen and Deb Keister that we would like to support a couple of the objectives on the Governor's Council at minimum, and that would be maybe the tri-state convening of multidisciplinary providers. We could do that. We've done it already. Quite honestly, we did it in March of 2018. We had 5-6 states in Charleston, mainly the state FQHC organization, and like in West Virginia, it would be West Virginia Primary Care Association. And we had the viral hep C coordinators for those particular states. And we want to share best practices because you don't want to have to recreate the wheel on this. What the Community Liver Alliance does, I don't know if Susanna's on or not, but the Community Liver Alliance is an advocacy group for patients, and they were originally a part of the American Liver Foundation until about, I'm going to say 7 years ago. And the problem was the money wasn't being kept in the region that we serve. And so Susanna and others started the Community Liver Alliance. At the time, I was a population health person at AbbVie. Hi, Gilead friends. and now we're all buddies. But, you know, I wanted to work in my home state without the pharmaceutical, you know, compliance issues that you have to, you know, fall under. So I retired in 2018 and have been working with Suzanne at the Liver Alliance, and we can train primary care providers, really virtually anyone that has access to and wants to treat patients for hep C, viral hepatitis, STDs. We've done that. I think last year we trained 30 primary care providers at a conference that we held in Charleston in October. We had a conference on the intersection of viral hepatitis and the opioid epidemic. And the night before we trained, it was actually 28 providers on treating hep C. And any way that you can make that happen, I know we have a restriction in the state where you need to get a consult with a specialist to write a prescription and treat hep C. And we need to work through that. We need to continue to train providers because that's who's closest to these patients. There's not a gastroenterologist or an infectious disease specialist right next door to where these patients are. There typically will be an FQHC or a primary care provider or a health department. And so honestly, and the treatments with Gilead, AbbVie, and others are so simple and so short term that they can be done, you know, by a primary care provider easily, in my non-clinical opinion. You know, so we want to do that type of work, you know, mainly in, I would tell you West Virginia, Tennessee, Indiana, Ohio, Pennsylvania, and Kentucky. And we've already shared one best practice with our coalition, if you will. I like this coalition because it's broader and it has many, many, many more moving parts. And so we hope to be a part of this with you. But we want to share best practices. Like I just recently did a comparison between West Virginia and Indiana, and I'd love to share it with you because there's a lot of similarities there. And we might be able to learn something from what they're doing and vice versa. So Indiana has a rural problem just like West Virginia does. And Deb Keister knows that very well. If you, I'm assuming many of you know Deb, but she's a professor at Marshall, and she pretty much wrote the Governor's Council plan. But Indiana has really orchestrated a very strong telemedicine program to reach these patients. You were talking about transportation, which is vital, and it's a determinant that we need to really support. But I put telemedicine in that avenue as well. We have providers that can use smartphones to treat patients, and I think that's something that I know we have the ECHO program at my alma mater, WVU, but it can't handle. It doesn't have the capacity, in my opinion, to reach all the patients that we need to reach in West Virginia, thousands of them, so, there are different ways to do that. And I hope we can explore them. In a nutshell, I would just tell you that we will support this stakeholder coalition and the Governor's Council as best we can, and we'll attend things that are live if we ever get back to that, and we'll attend all the virtual meetings. But if there's anything that we can do to support you more, please let me know.
Thanks, Jeff. Thanks a lot. And I think you bring up kind of a part that Marcus is going to talk about later, which is kind of some of the advocacy components. I think certainly who the providers are that can offer viral hepatitis treatment it's a policy issue as well as a public health issue. A double PCR test for people who are impacted by viral hepatitis, it's a policy issue as well as a public health concern. Accessing safe and clean syringes throughout the state in various venues, not just health departments. But it's a public health and a public policy issue. Overturning the ban on opioid treatment programs in the state. It's a policy issue and a public health issue. So we look forward to continuing to work with you, with the Liver Alliance, and with our other community providers to not just, again, support each other with, and don't forget, if all the people with Gilead have not made their contribution to SOAR yet, I'm bringing it up again. Don't try to look away. I know you. And I think Tiffany got off of the call too when I mentioned everybody giving $100. I'm just saying, I'm looking at who's getting off of the call when it's contribution time.
Tony Young, I'm still here.
Okay, note to self, make sure you make your contributions. $100 each, that's it. Look at that, that's 10 kits. Brooke, I'm out here working for you. You see me, right? All right, and tell Joe I'll send some more syringes down too. So thank you, Jeff. We're now going to go to our fabulous team from Gilead, who I pick on unmercifully, but they have come through like nobody's business. After our last call, I said, hey, we want to put together a training calendar for all of the providers in West Virginia. I want that to be everybody from the medical liaisons. I want viral hepatitis. I want HIV. I want training on HIV 101. I want y'all to help me help the peoples. This is basically what I said. it was a little nicer. Okay, probably not. So Trina, are you gonna lead this part, or Tanya, or Sherry, or Jared?
Look, we are a multidisciplinary team, so this is going to be a group effort, okay?
Okay, y'all knock it out of the park like I know you will.
Well, thank you so much, Tony. You gotta love Tony, y'all, right? So we are excited to be here, right, Stephanie? To have a conversation as your Gilead team. You know, Gilead has been doing this work for over 30 years, and we're really striving to really work importantly and invested in putting HIV forefront, as well as Hep C medications. You know, we have therapeutics that are across the HIV care continuum, and really want to ensure that you all know who your matrix team members are with in respect to. And we know that it's really going to take all of us to achieve a common goal in ending the HIV epidemic. And that's why we're really excited to work with Community Education Group to build a monthly training calendar to reach out to providers, allied healthcare providers, the community, patient support groups, and anyone else who's interested in learning more around HIV and HCV. So before I get started in introducing you all to the team, you know, we have to show a video. So we're just gonna do this within a couple of minutes, and this is
Y'all got video?
Look.
Man, oh man, it's Shevitz.
Look, I got control now. Love it. All right, so let's take our time and hold on, Marcus. Hold on, Marcus. Hold on, Marcus.
So while they're getting their audio visual together, I really do want to thank them all, because they really did come together at the drop of a hat for us. And when they get done, please know we're putting this training calendar together, but I also want to make sure you get introduced to these people individually, because they have resources and tools, some, you know, that they can just ship to you right away. And I'm like, let's use everything that we can at our disposal.
Thank you, Tony. All right, let's watch.
The average baseball stadium holds about 50,000 people, enough to fill a dance floor the size of a New York City block, or float down a river 53 miles long. It was also the number of people in the US who became HIV positive every year since 2003. Then, something happened. One by one, we said, enough is enough. Instead of waiting for a cure, we took action. We got tested and retested. We talked to each other, and we talked to healthcare providers about HIV prevention medicines and safer sex practices. We talked about STIs, condoms, and all the ways to help prevent infection. People living with HIV started treatment right away and stuck to it, which can prevent the spread of HIV through sex. And it worked. New infections went down, but we still have work to do. So let's all do our part and keep fighting. Because together, we can all help stop the virus. Find out what you can do at helpstopthevirus.com.
So thank you all so much for that. And I think, you know, we ended in saying enough is enough. And I just want to introduce you all to our community team for West Virginia. So I'm Trina Scott. I'm your community liaison, and really excited to be working in partnership with you all, and just have some notes on the screen of what I'm able to provide for you all. So staff and community education is one thing that we are known to do in excellence and in collaboration and partnership. Also offering patient engagement as well as support group trainings and conversations. Another critical part as we're talking about ending the HIV epidemic is really reviewing your protocols, helping you to develop some protocols that are really focused on HIV prevention, but also treatment as prevention and early starts. Having conversations around ending the epidemic. We're able to host roundtables, not only for your community support groups, but also for your staff support groups. As I'm learning, you know, having this conversation around ending the epidemic is something that we really need to do more critical engagement with, especially in West Virginia. And then the other two components are community events and partnerships. If you have a conference that's coming up, if you have a virtual pride or any type of ways that you would like to acknowledge or celebrate the community, I am here to support you with resources, materials, and also some dollars to put behind that. And then the last thing is around patient assistance. So Gilead has an advancing access program where we are critical in ensuring that patients can receive some of our therapeutic medications for zero to low cost. And so just really want to be able to support you all and all of your strategies, all of the ways to be able to connect folks to not only HCV, but also HIV treatment. So I want to introduce you all to our West Virginia HIV treatment team. And Tanya is on here, but you all have 6 treatment reps for the state of West Virginia. The top 2 are Natasha and Ann, and then we move over to Hannah and Tanya, and then we have Scott and Brian. So I just wanna have Tanya to be able to say a couple of words on what the treatment team will be able to offer you all as we build support in the state of West Virginia. Tanya.
Maybe she didn't want to pay that $100 and left.
Well, I know she is on the rough side of the mountains too, and maybe having some audio connections, but just want to let you all know that each one of these treatment reps are able to come in and have conversations with your providers around Biktarvy. Oh, there you go, Tanya.
I think I made it work, Trina.
All right.
I could hear you, but you couldn't hear me. So I'm here. Hi, guys. Thank you for having us on the call. We are very excited to be a part of the mission. I am one of your HIV treatment reps with Hannah, more in the Martinsburg Panhandle area, but as Trina shared, we've got reps all over the state, so no matter where you're located, we can definitely either get the information or resources to you or connect you with the rep in your area. But I wanted to make sure that everybody was aware that with Biktarvy, we do, and even our prevention, we offer resources as far as samples. We've got pill keychains, we've got pill boxes, we've got a great book in English and Spanish on 100 questions and answers regarding HIV. And then we also have educational programs for healthcare providers. Trina is your contact if you want to do anything with patient support, but if you want additional education when it comes to resistance, even COVID, or HIV in general, that is where your treatment team comes into play. Managed care is phenomenal, but I've heard, several times on the call about uninsured access. We have an amazing program with Gilead Advancing Access across all of our disease states, where if you have an uninsured patient or a patient with lapse in care, that we will make sure that patient gets the medication that's needed. So I have on my little picture, you can see my name and phone number. I will also drop it in the chat, and I am sure Tony will have a billboard out soon with all of our information on it.
Thank you, Tana. That's why we didn't put everyone's contact information on this slide. So if you need to get in contact with a treatment rep, we definitely will put you in contact with that person to establish that relationship or make a reconnection. And so not only do we have HIV treatment team, but we have a medical scientist who actually is on the call as well for our prevention team. Unfortunately, because of our engagement around PrEP in the state, we don't have a PrEP rep. However, we do have a prevention medical scientist, and we have Jared Coffey who is on the line, and he can tell you a little bit about the work that he can provide to your agencies and organizations.
Thanks, Trina. Hello, everyone. I'm Jared Coffey. I'm the HIV prevention medical scientist for the Ohio River Valley. So I cover Ohio, Kentucky, Indiana, Tennessee, and West Virginia. I live in Columbus, Ohio. I just started in January. So all of my life after training, I had 1 week that I was actually in the field, and the rest of it has been lived in this Zoom jail box that you see all of us in right now. But I'm definitely here to help you. And really, Trina has it on the screen. My job comes down to scientific exchange of data. So I'm here to answer any questions that you may have. I put my email in the chat box. But if you have questions like that may be off-label, a lot of times that will come to myself to help answer those questions for you. I'm here to support you with presentations. I know Trina mentioned implementation and protocol. I can help out with that as well. We have implementation decks. We have decks that differentiate between the prevention products that we have, and just many different presentations that we can give. The thing to remember about the medical scientist role is everything we do is reactive. So please ask questions, because that's the way that we get to talk and give you the information that you need. But we're definitely here to support, and we're going to be part of the training aspect that Trina is setting up. And Trina is bearing the brunt of all this. So snaps for Trina, because she's doing a fantastic job. But as medical scientists, we also give some of the commercial talks as well. So just here to support and happy to be part of West Virginia and the team. Also, one more thing. Jeff mentioned that he is like kind of cross-pollinating from different areas of the places that the Community Liver Alliance work with. And that's kind of what I do as well, with covering 5 states, Trina covering a couple states. Like, we can see what's working elsewhere. And if we can bring back ideas, then that's part of our role too. So just to keep that in mind.
Thanks, Jared.
I know. And just want to add one thing. Since you guys don't have a prevention rep in the area, I mean, feel free to reach out to me. Not that I cover prevention, but I can figure out a solution for you and connect you somehow to resolve any questions or problems you have, and we'll work at it from that angle.
Sherry, and sorry, Trina, I'm jumping in a second. Is Sherry, do you want to say what you do? It's my Zoom.
I was about to introduce Sherry, our Director of Government Affairs for the Mid-Atlantic region. Sherry.
Thank you, Trina. Trina is on it. I am Sherry Giorgio. I live in Nashville, but do have the responsibility for covering West Virginia. I've gotten to know Tony and several folks on the call over the past few months, and look forward to helping out, especially on the advocacy work that I know the group is going to be focusing on for 2021. So thank you for having us.
Thank you. And so that is your matrix team around HIV care and prevention. I did not highlight the Hep C folks, because they're going to be able to come on and do some additional conversations around the work that they do and can be doing in the state. I'm going to drop in on the chat box some of our upcoming trainings. I didn't want to put that on the screen because I want to focus really specifically on West Virginia. So we have one coming up on tomorrow with Dr. Joel Gallant, and he's going to be discussing HIV drug resistance in today's clinical practice. So I'll put that link into the chat box. And then next Wednesday, we're going to be having the Ending the Epidemic, Current Considerations and Treatment Strategies with Chris Roberson, who's a nurse practitioner out of Maryland. I put those links in there as well as my email address. Even if you just want to say, hey, Trina, I couldn't remember what you said on the call. Can we talk? I definitely want to be able to support you all in all of the great work and the new work that you're going to be doing in West Virginia. Thank you, Tony.
Thank you. And so so you'll know, after our last call, what we started putting together was a training calendar. And we originally were like, okay, just throw everything on the calendar. But then we said, no, let's kind of do it in 3 different areas. So we're looking at individuals, organizations, and medical providers. And we wanted to do that in a way because of some of the limitations that Gilead will have of what conversations, and not just Gilead, we're talking to y'all. I know y'all are the prettiest girls at the dance, but y'all not the only ones. So we're talking to Merck, and I thought that was a good analogy. So we're talking to other pharmaceutical companies and, like I said, other training institutes to also be able to fill up this calendar. But we wanted to have trainings at different levels. That doesn't mean you can't attend it unless, for example, they say, you know what, this is for doctors only. And there are some spaces that are specifically for doctors. We'll try to get those trainings adapted for our allied community partners and for individuals as well, but there just may be those spaces. So Marcus, I know that we had started to populate that calendar. We're also going to be putting out probably a quick survey to some of you about what are the types of trainings that you feel you need in your organization and institutions. Some people may say, well, we need capacity building training, and that's not what they do, but that's what the AIDS Education Training Centers will do. So we want to, again, we see this time and this vehicle as a way for us to support each other. So if we hear of a grant, we're going to tell everybody about the grant. It's not just CEG's grant. Like Trina just told you, hey, if you're doing an event, call her. They could probably support you. They can give you a key ring, but they also might be able to give you some money to help you buy those test kits that you need, Brooke. I'm just saying, why am I out here working for you today? I need a check when this is over with. So, but again, I mean, for those of you that have worked in West Virginia for years, those of you that work in West Virginia now, I think that you all know that resources are limited. And I just really figure the only way we're going to get this done, and the only way we're going to move this boulder up the hill is if we do it together. I can't hold on to information or resources that I don't pass on. We have got to do this. My new saying is, I don't need allies, I need comrades. We're in, and I need accomplices. We are at war, and we have to fight these epidemics. We have to fight these systems, and we have to rebuild them and retool them where we can. I want to thank everybody from the Gilead team, and I really do expect that $100 each to make it to Brooke. Y'all are laughing. Trina knows me very well, so Jared, I'll be on your phone. Sherry, we already have a meeting scheduled. I'll ask then. So, what'd you say?
I said, my.
But I thought you said you were paying for everybody. My fault. I misunderstood you.
Marcus.
So we are at the end, near the end. I know Marcus, we're not at the end. Marcus has some things. And Marcus is shaking his head. No, you've gone off script way too much now. So is it your turn, Marcus, or do I have something else?
It is my turn. I've been waiting so patiently. So I'm going to do a quick screen share with you. And these are the slides that we were going to present at the beginning, but we've moved them to the end. So I'm going to explain a little bit about what the West Virginia Stakeholder Coalition is all So Tony kind of went over this today, and what we're really trying to do is engage community members, organizations, and providers to make sure that the issues that we're facing around HIV, substance use disorder, and viral hepatitis are addressed in a way that is actually functional in a state like ours. And the only way we can do that is by deconstructing the silos that exist between HIV, SUD, and viral hepatitis. So kind of what Tony's been talking about pretty much throughout the meeting is that this is an opportunity to kind of create, foster, and develop relationships between members of the community, between community-based organizations and rural health service providers, and also with medical providers to build new linkages to care. And one of the ways that we're going to do that is what we're premiering today, which I'll talk about in just a moment. Additionally, we're going to be offering a series of monthly training and technical assistance opportunities for the various levels that Tony talked about, community, organizations, and providers. And we'll also be offering some advocacy training, training around organizing advocacy efforts, and then engaging with public officials on the issues that are important to you, important to us, and important to all West Virginians. So in general, what we're looking at is meetings will be held on the second Monday of every month, with the exception of national holidays, which is why we didn't have one yesterday. So we've got meetings scheduled up through March of next year. So whenever you filled out the form and you got 6 notifications that you've been registered for meetings, that's why. And then I'm really excited and relieved, actually, to be sharing the next thing with you. So we have just launched today our new West Virginia statewide resource guide. This is a state and county level guide to healthcare, HIV, substance use disorder, viral hepatitis, and other social service resources that has an interactive map that users can select their county to find the resources where they live, and basically identify gaps in services that they can then, we can then work to build. So obviously, my colleague Amanda and I have been laboring over this for the past 2 weeks to try to make this happen. And we know that we have not caught every resource in the state or in every county. So what we've done is we're allowing user submissions to submit resources to this guide. And as soon as we receive them, we will update our list, and then we will be able to broaden that guide. We also are putting together our COVID-19 relief packages next week, and we will begin shipping those out to our distribution partners. And then finally, we are announcing today our World AIDS Day Advocacy event, and this will be held on December 1st from 12 p.m. to 2 p.m. And it will coincide with the release of our statewide report on HIV, substance use disorder, and viral hepatitis. And we will also have state of the state presentations from several of the people from our state and local governments, community-based organizations, and hopefully we'll be able to wrangle in a couple of our newly elected officials to kind of get on the phone with us so we can advocate with them. And that is all I have. When I send this out to you, everybody will have a fully interactive PDF, and you'll be able to click on those buttons and links and register and help us fill out our guide. So thank you guys so much.
Thank you, Marcus. And there is no me without Marcus, Amanda, and Emma. They let me kind of be me and work really hard so that we look good. And I want to thank them very much for pulling this all together and all of the work that they do, particularly in the areas of policy, advocacy, putting together that website, and all of that. We have a few minutes left. Did anybody have a question last minute? Did anybody need Brooke's information again? You want to put it in the drop it down in the link one more time on our way out. And like I say, our goal, our job, we feel like, is to also support our partners. So, today, I'm like trying to get money to SOAR. I think it's a great program. With our COVID kits, we're working with Health Right in Morgantown. We're getting some space from them and some volunteers that we're compensating from them to, put the kits together. But, I think we all have to figure out ways in which we partner and collaborate to help each other be successful, as I deconstruct the silos which exist between viral hepatitis, HIV, and substance use disorder in the state. We will be keeping you up to date with our policy work. We'll be keeping you up to date with the training calendar. And I want to thank you all for spending 2 hours of your Tuesday afternoon with us. If you need something from us, want something from us, have a good idea, think we should do something, want us to call somebody and yell at them, we'll do that too. But have a great rest of your Tuesday. And thank you, Gilead. Thank you, Liver Alliance. Thank you, SOAR. Thank you, DHHR. And at least nobody was, actually one person did give their phone number. Tanya was crazy enough to put her phone number in there, but okay. You can't train everybody. Have a great Tuesday, everybody. Thank you.